Hi, my name is Ryan Rivera, and I am presenting case connections for Unit 4 in biochemistry. I'm going to start with case number 2. Case number. Which case am I starting with? Yeah, case number 2, the 4-day-old infant with high phenylalanine levels and the diagnosis of PKU. The first question posed in case 2 is, what are the potential causes and presentation of PKU? Essentially, the question is, which amino acid may become essential in the case of PKU? Essentially, the short answer is tyrosine would become essential because tyrosine is made from phenylalanine, and in PKU, phenylalanine cannot be cleared from the blood because it cannot be converted to tyrosine by phenylalanine hydroxylase because of a genetic defect in the PAH gene, which leads to toxicity of phenylalanine in the blood. So normally, tyrosine, which just has an additional hydroxyl group, more than phenylalanine, is converted by phenylalanine hydroxylase. But in the case of PKU, this cannot happen because of the genetic defect that causes a problem with the activity in phenylalanine hydrolase. So, where tyrosine was considered to be non-essential before because it could be formed from another amino acid in the body that is consumed, it is now considered to be essential because it cannot be consumed, cannot be made within the body, and must be consumed and supplemented in the diet. The next question for this case is, what are the potential causes of the presentation of PKU? And some of the potential causes, or the potential cause for PKU, is the mutation in the PAH gene, which I was already talking about a little bit. But essentially, there are hundreds of different mutations that can happen in the PAH gene, and some of them can result in either altered or just reduced activity in the hydroxylase enzyme, and some of them result in classical PKU, which result in no conversion of phenylalanine to tyrosine. And in that case, obviously, is the cause for PKU or phenylketonuria. So the next question we're asked is, how would we summarize the results for a test that we presented a graph for patient A and B, for patients that were given given a BH4 loading test, and then a meal, and then their levels of phenylalanine were checked at like 4 and 8 hours, I think. And so the way I saw the graph and the way I interpreted it was that patient A, their phenylalanine levels in the blood continued to rise after BH4 was given and after the meal was consumed, which indicated to me that BH4 was not able to facilitate as a cofactor phenylalanine conversion through phenylalanine hydroxylase. And so I thought that patient A might have a genetic mutation that directly affects the production and activity of phenylalanine hydroxylase on the presenting the symptoms of classical PKD, which is the complete inability to convert phenylalanine to tyrosine at all and clear it from the blood. So in patient B, the chart indicates that phenylalanine levels in the blood did drop after they were given BH4 and after they ate and consumed aminoproteins, which indicated to me that the presence of the cofactor BH4 did facilitate the functioning of phenylalanine hydroxylase to convert phenylalanine to tyrosine, and it did ultimately clear levels of phenylalanine from the blood. So I thought that patient B could have a BH4 responsive PKU, which is a lesser or severe form of PKU, in which the activity is just restricted or modified in the production of hydroxylase to where it can still function, but just not fully. And we see that in the chart with the drop in phenylalanine levels, as opposed to patient A, which had the classical symptoms of them not. So the next case I'm going to talk about is case number 3, which is the 47-year-old gentleman who was diagnosed with gout, came to the emergency room with acute pain in his big toe and problems walking. The doctor diagnosed him with gout already previously, and we are asked to examine which is the best explanation for his presentation of gout, and explain why the other choices are not consistent with the data that we're given. So out of the choices we're given, some of the things that I went through to try and elicit my response were obviously, one, the physical findings of acute pain with no known mechanism of injury and his diagnosis of gout, and then I looked at the labs. The plasma urate levels of uric acid were high, and so he had an excess of uric acid in his blood, and uric acid is produced during the breakdowns of purines, which are found in certain foods that are also formed in the body. And then his urinary lab of uric acid was actually, I wouldn't say normal, it was actually below normal, indicating that he is not excreting the high urate levels that he's got developing in his blood, which is obviously leading to his gout. So on to the question, which is actually, what is the best explanation for the presentation of gout? From the options we're given, I chose that the overproduction of purines is the best reasonable reason for the gout that he's experiencing, because of the excess consumption of fructose in his diet, and the fact that most uric acid is filtered in the kidneys and eliminated in the urine, and the rest is eliminated in the gut when it's cleaved by bacteria and eliminated in the feces. So obviously, one of the other reasons I think that it is caused by overproduction of purines is that PRPP, which is phosphoribosylpyrophosphate synthetase activity, can be, I believe that was accelerated in his case because of the additional fructose that he was consuming in his diet. One of the other options we were given to choose from was, could a decreased salvage of purines cause his gout? And while it can cause gout, in his case, he's 47 years old, and I don't think it's a decreased salvage of purines causing this with him, because it would most likely be caused by a genetic defect that would have most likely presented earlier in his life, such as adenine phosphoribosyltransferase deficiency, and or like a Lesch-Nyhan syndrome, and those definitely probably would have presented earlier in his life with some other issues before he was 47 years old. The final option we were presented with is or was decreased urinary excretion of uric acid. And I don't think it was that. It could have been this, but given the other circumstances, I still believe what I said earlier about the overproduction in purines to be true. This would require additional testing, which would need to be used to determine glomerular filtration rates, and activity of his kidneys. Since the majority of, or 2/3 of uric acid is excreted in the kidneys, and like a third is excreted by the intestines, and 90% is actually reabsorbed. There is some involvement, definitely, with urinary excretion of uric acid to decrease urinary retention of uric acids. So I don't think it was that. The final question asked is about the patient telling you that he has recently switched from diet soda to regular soda, and what impact would this dietary modification have on his gout. So some long-term implications that can, if you continue to consume things that can ultimately lead to the production of uric acid, and you're having a problem clearing it from your body to begin with, long-term can cause gouty atrophy, include joint damage. It can obviously create kidney stones, which are extremely painful and can be a huge problem, and eventually can lead to kidney problems or even failure. And another severe symptom that can develop is tophaceous gout, and that is where repeated flares of gout result in tophi, which are just large numbers of urate crystals, and they can actually get into the joints and the fluid in the joints and the sacs, synovial sacs, and damage the bones and cartilage, and actually cause erosion and joint damage and deformity as well.